because hypoglycemia now we know has been implicated in mortality. We are interested in if hypoglycemia begets more hypoglycemia, how to interrupt that cycle, what type of hypoglycemia we might or might not see with the SGLT2 inhibitors, and what's the pathophysiologic basis for the hypoglycemia. What have we learned about the cardiovascular risk with hypoglycemia? And I know you've done a lot of work in this space, so tell us about this.
So let me pose a question to you.
Okay.
You're a hypertension guy. You're treating a patient for hypertension, and you put them on a drug, and they call you and go, you know what, every time I get out of bed in the morning, since you put me on this medication, I'm feeling lightheaded and faint. Right. What do you do?
I'm very concerned. First, if I have the right diagnosis, make sure they're hypertensive because they might be a white coat type. And of course, I'm going to back off on the drug, reevaluate them, and cause them no harm. So I'm definitely very concerned about orthostatic hypotension.
Okay, so in diabetes, our patients are put on medications, develop hypoglycemia, call their doctor and say, okay, I've got hypoglycemia. Do we drop the offending agent in diabetes? No. Half the time we tell them, well, just take a bedtime snack and that way you won't go low. Or we continue the medication at a lower dose.
Right.
Dose doesn't really correlate that well with hypoglycemia for drugs like the sulfonylureas, for example. You can get as much hypoglycemia on 2 as you do on 4. So that doesn't eliminate the problem, it just reduces the frequency. But I think one of the big points about hypoglycemia is twofold. One, most of the time it's asymptomatic. You know, continuous glucose monitoring shows it's occurring 45–50% of the time in type 2s, where we're going, well, we don't have them on any agents that can cause it. 45 to 50% of the time it's occurring. The second point is, even when it's symptomatic, it's very much like, okay, you see one deer along the side of the road, you know there's probably 2 or 3 others waiting to run out in front of your car. If you have one hypoglycemic episode, there's a couple other that the patient isn't perceiving or not noticing. So if you've got one, you've got a problem. You know, patient says, well, I didn't eat for 12 hours and I exercised and then I went low, different. But spontaneous hypoglycemia, if you have one, you've got a problem. And there's physiologic reasons for that. But why is it such a problem? Well, when your blood sugar goes significantly low, your QT interval gets prolonged. Drugs can't come to market for any indication if they prolong the QT interval. That's a safety thing that every new medication has to address. You get a warning from the pharmacist if you want to get a Z-Pak to someone on Celexa. But you don't get a warning if a patient's on a sulfonylurea, which if their blood sugar drops down to 55 will prolong their QT interval while they're on the Z-Pak and Celexa. And so QT interval prolongation and the potential for arrhythmia is probably one of the reasons that we're seeing an association between hypoglycemia and mortality in our tight control studies. Let me just forward through this slide because this is really physiologically important. One single episode of hypoglycemia, one, reduces your counter-regulatory hormonal response to recover from it, but also blunts your awareness for the next one. So it's a double whammy. Just a single episode, you can see on this slide that hormonally your recovery is impaired after one, but symptomatically you don't feel it as well either. This is especially true for overnight hypoglycemia. So when you have one episode, it's setting the table for more, and it's setting the table for more that the patient isn't aware of. I think one of the other subtleties, though, Jan, for those of us on the front lines is we don't ask the right questions for hypoglycemia some of the time. And so, for example, we always ask, oh, you're shaky, you're sweaty, you're jittery. Well, that's fine if you're low because your blood sugar is going like this. If you're on basal insulin and your blood sugar is going like this, you may not have adrenergic symptoms at all. And so we've got to tailor our questioning of our patients to more, you're getting sleepy at any time during the day, confused, because sometimes asymptomatic just means wrong questions. And so a little bit more teasing when a patient is on a drug that causes hypoglycemia. We talked about the SGLT2s as monotherapy. They don't. In combination with most other therapies, there's a slight chance, because whenever you're on more than one drug, even though each individual drug has a low incidence, it's just increased a little bit. And when you add them to insulin or sulfonylureas, obviously the risk of hypoglycemia is greater.